Good morning, everyone, and welcome to a Cystic Fibrosis Foundation sponsored virtual briefing regarding protecting vulnerable populations while America reopens, expanding paid family and medical leave. This briefing will be recorded. It is an open forum. If you have any questions, you can submit them anonymously through the question chat, and we will have them asked at the end of the presentations. Without further ado, I would like to introduce Mary Dwight, Chief Policy and Advocacy Officer of the Cystic Fibrosis Foundation, and today's moderator.
Hi, everyone, and thanks for joining us. And it's great to have you with us. As Jonathan said, I'm Mary Dwight with the Cystic Fibrosis Foundation, an organization that supports the more than 30,000 people with cystic fibrosis, chronic and genetic disease that impacts the lung and other organs. I'm so delighted to be joined by a very accomplished and distinguished panel of speakers to discuss the importance of protecting vulnerable populations like those living with cystic fibrosis and cancer in the age of COVID-19. I know we've all heard this before on just about every call we've been on, but this really is an unprecedented time. Across the country, we're watching many different approaches as states begin to reopen their economies. Some states are moving quickly to completely reopen, and others are pursuing more staggered strategies. For example, Texas is preparing to open bars and movie theaters this weekend. Meanwhile, here in Washington, D.C., only 6 non-essential businesses are open for grab-and-go service, a wide variety. As each state plots its own path towards reopening, employers are charting different courses as well to bring back their workforce. And at the Cystic Fibrosis Foundation, we are hearing daily from people living with this disease and their family members who are facing a devastating decision. Should they place their health or the health of their loved one at risk by going to work, or lose their income and, importantly, their healthcare coverage altogether? These folks we're hearing from are teachers, healthcare workers, nursing home assistants, warehouse workers, police officers, firefighters, and many more. We're concerned that some states are encouraging employers to submit information about employees who choose not to come back to work out of fear of contracting COVID-19, and states who have indicated that this information will be used to determine whether unemployment benefits or would be denied. This approach paints a black and white picture and fails to recognize the challenge, in fact, the real risk that returning to in-person work places on some in our community, including those with serious health conditions. As a country, it's time to understand that there's not a one-size-fits-all approach to going back to work, and our policies need to support that. It's critical that we create a federal public standard that allows each one of the 50 states to reopen without putting those who are most vulnerable at further risk. It's also going to help our economy open back up more quickly. As I'm sure many of you know, there's significant doubt among public health officials that our nation's public health infrastructure is prepared to adequately test, trace, and isolate at the scale necessary to ensure that all workers, including those with serious medical conditions, can safely return to the workplace. Yet, for those who need the income, as well as access to their employer-sponsored health insurance, losing their job or opting into unemployment insurance is not a real choice. At the same time, businesses are contemplating reopening and are encouraging Congress to limit their legal liability for employees and consumers exposed to COVID-19. We think protecting vulnerable populations is just as important as protecting these businesses. And in fact, if we do it smartly, we can accomplish both goals together. We're here today to talk about the importance of a federal expanded paid leave program for people at high risk of adverse effects of COVID-19 and their working loved ones. With the Families First Coronavirus Response Act, or the CARES Act, Congress took an important step of expanding paid leave to certain employees without access to childcare. Under this expansion, the federal government shouldered the financial cost associated with expanded paid leave. However, employees considered essential were not guaranteed this benefit, and employers with fewer than 50 and more than 500 employees were exempt. We call on Congress to expand paid leave to people at high risk of adverse effects of COVID-19 and their working loved ones, so that these Americans no longer need to worry about making an extremely difficult choice during an extremely uncertain time. No one should have to choose between placing their loved one's health or their own health at risk by going to work, or losing their income and their health coverage altogether. Now, the solution we're proposing should not exist in perpetuity, and we're going to talk more about what that might look like in our panel today. But as part of this relief effort to get Americans working again, this piece is essential. Protecting our most vulnerable from COVID-19 while allowing the opportunity of work to those who can is the sweet spot we need to hit. Nobody should sacrifice their health for a paycheck. Enabling our most vulnerable populations to continue to take the necessary precautions will better facilitate the reopening of the economy we all want. We were grateful to see this ask included in the HEROES Act passed by Congress last Friday, and we urge Congress to ensure it is in any next negotiated legislative package. With that, I'd like to take a moment to introduce you to today's panelists, and then we'll hear from them a bit more on each of these conversations. First, let me introduce Dr. Otis Brawley, the Bloomberg Distinguished Professor of Oncology and Epidemiology at Johns Hopkins University. He's a board-certified medical oncologist and an epidemiologist. He's an authority on cancer screening and prevention, and he leads a broad research effort on cancer health disparities at the Johns Hopkins School of Medicine. From 2017 to 2018, Dr. Brawley was the Chief Medical and Scientific Officer at the American Cancer Society. He is the recipient of the U.S. Public Health Service Meritorious Service Award, the Department of Defense Distinguished Service Award, and the 2019 American Medical Association Distinguished Service Award, and also a member of the National Academy of Medicine. Next, Dr. Jonathan Ellen. Dr. Ellen most recently served as the President, CEO, and Physician-in-Chief at Johns Hopkins All Children's Hospital in St. Petersburg, Florida. During this time, he worked to transform the hospital from a pediatric referral center to a leading academic health system focusing on research, education, and patient care. Dr. Ellen retired as a professor of pediatrics from the Johns Hopkins University School of Medicine and was named Vice Dean for All Children's Hospital in 2011. Today, he continues to be a leader and an innovator in the health field, combining his experiences as a physician, a respected hospital executive, a world-class epidemiologist, and an academician to strengthen the practice of medicine, and most recently co-authored a Manhattan Institute article entitled A Strategy for Reopening New York City's Economy. We're also joined by Monica Bryant, a lawyer focusing on the health and employment rights for those with a cancer diagnosis, speaker and author, who is dedicated to improving access to and the availability of quality information on healthcare issues. She's the Chief Operating Officer for Triage Cancer, a national nonprofit organization that provides education and resources on cancer survivorship issues. She has years of experience in the cancer community and previously served on Capitol Hill for 2 members of Congress. Last, but certainly not least, we're very delighted to be joined by Katie Fielding, a 38-year-old woman living with cystic fibrosis. She was diagnosed at infancy and has been a public school educator for 16 years. In fact, right now, she is leading technology support for her team, so it's very busy, as you might imagine. She's been recognized as a Google Innovator in 2018 and the Virginia Society for Technology and Education's Tech Coach of the Year for 2019. She has a passion for using technology to improve the educational experience for chronically ill students who are home bound. With that, I'd like to kick off the discussion and turn it to Dr. Brawley to get us started. Dr. Brawley?
Good morning. I'm Otis Brawley. I'm a medical oncologist and epidemiologist. I'm here to talk a great deal about the effect of COVID-19 on the cancer community. That's really the area where my expertise is. There are about 1.6 million Americans who are diagnosed with cancer every year. We have more than 16 million cancer survivors. Now, this is a disease that came to the United States in January, really came to the world in December. We're still learning a great deal about it. What is, however, very clear is cancer patients who are in treatment are at higher risk of getting the COVID-19 virus, and cancer patients in treatment are at higher risk of having bad outcomes, of dying from the COVID-19 virus. Now, cancer is about 200 different diseases, and it's very clear that people who have hematologic diseases, lymphomas, leukemias, are at higher risk of problems than people who have solid tumor diseases. But people of all spectrums have worse outcomes than people of the same age who do not have cancer. There's a special problem in that we have cancer survivors who have been treated with chemotherapies and other interventions and are immunosuppressed. There's increasing data just in the last 3 months that we've been studying this disease, that these individuals, after having successful treatment for their disease, are at greater risk of catching the disease, and if they catch the disease, at greater risk of having a poor outcome. We're talking about surveys that have been done in China, Italy, Spain, and New York that show cancer patients have 2 to 3 times higher risk of death once infected with COVID, and cancer patients who have infections after having a leukemia or lymphoma having an even greater risk of death. So I'll stop at that point and let the other speakers speak.
Thank you so much, Dr. Brawley. And now I'd like to turn it to Dr. Ellen.
All right, thank you for having me today. This is really an exciting opportunity to catch you all up on our advocacy efforts in this area. My name is John Ellen. I'm a pediatrician, epidemiologist, and public health practitioner with over 30 years of practical experience combating the spread of infectious diseases. I'm here today to share with you my thoughts on why extending FMLA is an essential part of the broader strategy to end stay-at-home orders and reopen businesses and public life. As we all know by now, the concern that we were on a path to unimaginable numbers of deaths due to the COVID and overwhelming the healthcare system, coupled with the recognition that we lack sufficient testing and contact tracing, moved government officials to take extreme steps of ordering people to stay at home. This devastated the economy, and millions have since lost their job. Fortunately, as a number of new cases and deaths have begun to recess and testing has increased, most of the country has begun to pull back on stay-at-home orders to some degree, reopen businesses, and attempt to resume a modified form of social life that includes social distancing and masks. As we move forward and start to settle into this new normal that allows people to get back to work while we wait for a vaccine, it is essential we do not backslide to rising deaths, which could, at the minimum, scare people from going out and engaging in businesses, and at the extreme, return us to stay-at-home orders. Based on our current understanding of the infection, the most likely population to experience increases in deaths with the reopening of the economy will be the elderly and those with chronic disease. This focuses attention on nursing homes, which is an essential component of the strategy to limit the impact of COVID as we reopen. And as colleagues and I argue on a recent online Manhattan Institute article, we also need to protect those with chronic disease such as cystic fibrosis if we are to continue our march towards a more normal social and business life. We are advocating today that the future legislation protects those with cystic fibrosis and other chronic diseases by expanding FMLA so that workers with CF and caretakers of children with CF are not forced to go back to work, risk becoming infected, and causing those with cystic fibrosis to die. In short, without expansion of FMLA, we will see increases in deaths, and irrespective of how government officials respond, the general public will react and pull back on social interaction. This cascade of events will easily slow any economic gains we have achieved since ending stay-at-home and cause unnecessary pain for the country. Thank you.
Thanks so much, Dr. Ellen. And now I'd like to pass it to Monica Bryant.
Thank you so much, Mary. I'm delighted to be here. My name is Monica Bryant. I am, in fact, a cancer rights attorney and chief operating officer for a national nonprofit. Next slide, please. So I'm here today to talk about the employment rights that exist for individuals with serious medical conditions and what can be done to provide some additional protection. The concept of paid family leave is not new or unique by any means. Other countries have these protections, some states have these protections. But the protections are certainly not comprehensive, leaving millions of Americans left unprotected. And of course, the population we're focusing on today are those with serious medical conditions and disabilities who are particularly vulnerable. These medical conditions include things like cystic fibrosis and cancer, as we've heard today. Even individuals who aren't in active treatment may still be immunocompromised and particularly susceptible to COVID-19. Now, what is unique about our current situation is when discussing protections, we can't just be looking at how to protect the individuals with the serious medical conditions, but we also have to be looking at protecting their caregivers due to the highly contagious nature of this virus. Now, over the last several decades, there have been bipartisan efforts to protect working Americans who have disabilities, including those who have chronic and serious medical conditions like cancer. And in looking at the legislative history of those efforts, there's been a consistent appreciation for the importance of keeping Americans at work. Now, there have always been gaps in these protections, but those gaps have certainly widened during this current pandemic. Next slide, please. Starting with the premise that a majority of Americans want to work, and they want to do so for a variety of reasons that may be above and beyond a paycheck. And I certainly think that's true because if a paycheck were the only reason people worked, there wouldn't be nonprofit lawyers, and there likely wouldn't be as many congressional health staffers. So the Americans with Disabilities Act is a federal law that provides protection against discrimination for individuals with disabilities and their caregivers. Now, for the individuals with a disability, in addition to that protection against discrimination, they're also entitled to something called a reasonable accommodation. And reasonable accommodations can be a wide variety of things. Particularly relevant right now might be the ability to telecommute, working from home or working from a different location. Perhaps it's about changing shift, so someone might be able to work during less populated hours. It could also mean extended leave. But there are some gaps in the ADA. For example, there are some jobs that can't be done remotely. Also, the ADA doesn't provide reasonable accommodations to caregivers. We're also hearing some instances of employers pushing back on individuals who have compromised immune systems using reasonable accommodations, in that just having a compromised immune system doesn't give rise to a disability under the ADA's strict definition. Additionally, some employers might be able to claim it's an undue hardship, which is the legal standard under which they can refuse to provide a reasonable accommodation. And that's particularly relevant right now, given the economic hardship so many employers are facing. Next slide, please. So if someone can't continue to work, what options do they have to take time off? Some employers provide paid sick leave or vacation time. Some states or localities will provide some options for paid sick leave, but as you can see, it's in a very limited number of states. It's also for a relatively short duration, so certainly not even the incubation period that we've been hearing of COVID-19. Employees often aren't allowed to accumulate that paid time off. It's often not job protected, which means in many instances, employees can actually be let go during their paid sick leave. Next slide, please. So for individuals who don't have access to state or employer-based leave, one option might be the Family and Medical Leave Act, or the FMLA. This federal law allows for 12 weeks of leave to care for your own serious medical condition or to act as a caregiver to a seriously ill child, parent, or spouse. This leave is in fact job protected and health insurance protected, but of course there are gaps here as well. There are approximately 50% of Americans who are not eligible to use FMLA leave because either they don't work for a large enough employer or they haven't worked for that employer long enough. The other challenge is that FMLA leave is unpaid. And we know about 46% of the employees that are eligible for FMLA don't take it because they can't afford to do so. Also, when we're talking about caregivers, there is limited options for wage replacement. Even if somebody has purchased disability insurance, that's not going to be an option for a caregiver because they're not the ones with the disability. The FMLA also has a very limited definition of family. It's a seriously ill child, parent, or spouse, which means that somebody can't be taking time off under the FMLA to care for a sibling, an aunt, a grandparent, a domestic partner that they are not legally married to. Additionally, FMLA leave is health insurance protected, but the employee still has to cover their portion of the health insurance premium. If they are not bringing in any income, that becomes even more challenging. Additionally, employees are only entitled to 12 weeks of leave per year. And when we're talking about individuals who have serious medical conditions, it is not unreasonable to assume that they may have already exhausted their 12 weeks of leave at this point in the year for another reason, perhaps the birth of a child or for the treatment of their underlying condition. Next slide, please. So in the Family First Act, of course, Congress did pass a provision for emergency paid sick leave up to 80 hours. The challenge here for the individuals that we are talking about today is that the qualifying reasons for the emergency paid sick leave under Families First exclude vulnerable populations. So in order to truly be protective, we would need to expand the reasons for this leave to include self-quarantining due to being high risk and the self-quarantining of a caregiver of somebody who is high risk. And of course, there are also those exceptions for certain employers based on size and for essential health. In addition to the paid sick leave, Families First did include paid family leave. But the challenge with the paid family leave is that the reasons for leave is even more limited than the original FMLA in that it's only available to individuals taking the time off because they don't have childcare options. So this excludes childless adults. And this is just a new reason for leave under the FMLA. It's not additional time. So again, the issue of having exhausted your FMLA leave is still an issue here as well. Next slide, please. So if an employee can't work with reasonable accommodations and they don't have options for job-protected time off, the next option is leaving their job and potentially collecting unemployment benefits. Now, of course, the CARES Act did expand unemployment benefits by adding a federal benefit. The issue with the CARES Act is that many of the people in the populations we're talking about today want to stay at work. They just need a little bit of help in order to bridge that gap until they can go back to work physically safely. The other challenge with unemployment benefits is it doesn't replace 100% of somebody's working income. That's going to cause further economic damage, and that economic damage is compounding the financial toxicity that these individuals are likely already facing as a result of the high cost of care for their underlying condition. Likely, if they're on unemployment, they've now lost their employer-sponsored health insurance, and so these individuals are now faced with a decision for what to do for health insurance. Chances are their new option is going to rely on some sort of government subsidy in order to access the health insurance. And that could be the financial assistance available in the state health insurance marketplaces. It could be that now these individuals are eligible for Medicaid based on their financial situation. The unemployment benefits are also short-term. They only go until the end of July. In August, these individuals are now going to be left without the added financial assistance and without a job. Whereas if we were able to provide the paid leave for them to bridge the gap until it's safe for them to return to work, they could return back to their original jobs. Next slide, please. Now, of course, I fully recognize whenever we are discussing policy changes, there has to be a weighing of the pros and cons and a balancing of the benefits. But I would argue that providing a paid sick leave option for vulnerable populations during COVID-19 is in fact mutually beneficial. So certainly it's beneficial to the government because we are keeping people at work and we're maintaining their income, which ensures that they will continue to contribute to federal and state income taxes, to Social Security taxes, to Medicare. It's also going to reduce a reliance on government benefits like unemployment and Medicaid. It's also beneficial for the employers. So certainly with a paid family leave, they're able to keep valued employees and maintain workplace morale. They're also able to avoid the additional costs of having to hire and retrain new employees. And then, of course, it's beneficial to the families that we're talking about. They get to keep their jobs and maintain their income. They get to keep their incredibly important health insurance. They get to continue to contribute to society and, of course, maintain their health and not have to make that choice between their livelihood and their life. So with that, I welcome questions. Thank you.
Thank you so much, Monica. That was really helpful. And I'd love to turn it over to Katie Fielding now.
Good morning. I'd like to thank the CF Foundation for having me represent the CF patient community and their families. As a public school teacher of 16 years, I'm currently fortunate to be able to be working from home, like most teachers are across the country. However, I feel and face great uncertainty as we look ahead to the fall and schools reopen. When schools reopen, I likely won't be able to return on the same schedule as my healthy colleagues and students. While I look fairly healthy now, that wasn't the case 6 months ago before I started Trikafta, an innovative CF drug that costs $300,000 a year. Before this, my lung function was consistently in the 40% range, affecting each aspect of my life. For comparison, someone normal, healthy, would be in the mid-80s at my age. It's hard to conserve sick leave when you're constantly needing to use it. CF is a multi-system disease. I see multiple doctors, so I have to use my leave for appointments and those days when I am sick. So it's hard to collect that over time. So while I'm healthier now during this pandemic, ironically, I'm left wondering how my employment will be affected once I use my pool of sick leave that I do have. I am dependent on my employer's health insurance for accessing my CF care and medicines, which out of pocket would be over $500 million a year. Additionally, I live with my partner of 6 years. Because of our non-married status, FMLA wouldn't cover him staying home. He works in a client-facing business, and once his job returns to the office, we wouldn't have any legal protections that would allow him to stay home, so I don't face possible exposure. Would he have to move out of our apartment to protect me? For how long? And what other hardships would we face because of this? These are just a few questions and uncertainties that we are currently experiencing. But my experiences are not mine alone. Other CF families are facing these hard decisions, and I'll share a few of their stories now. For example, a woman in Missouri married to a man with CF had to quit her job as a nursing home attendant because the company deemed her an essential employee and denied her unpaid FMLA because she had no underlying health condition and her husband was not considered sick. She quit her job before they could fire her, but to my knowledge, she is not yet qualified for unemployment insurance. She also carried the health care for her family, which her husband relied on, again, to get Trikafta and all of his other drugs. She did not want to quit, but felt she had no choice to protect his health. There's also a nurse with CF in New York who's currently using her paid time off, but once she runs out, she's worried she'll have to return to work or leave her job and lose her benefits. She's already used her FMLA this year and does not have that to rely on during the pandemic. She has limited options. In Louisiana, there's a CF mother whose employer allowed her to work from home, but was notified that her office was to be opened in late April. She requested to remain working from home because her daughter's CF, but the management insisted that all employees had to return to work. She returned to work last week to maintain her employment. Her husband was never able to work from home and has been living in a camper to avoid exposure for their daughter. And in Ohio, there's a family consisting of a pediatric nurse and a firefighter. The nurse took 7 weeks unpaid leave before being forced back to work. It was heavily implied that she would lose her job if she did not return. The firefighter, essential worker, was unable to take off. Concerned about finances, health care, and if the husband would need to isolate away from his family. The Cystic Fibrosis Foundation is now getting multiple calls a day from people with CF and their loved ones whose employers are telling them they must go back to work or risk getting fired. This is untenable for the people with high risk to COVID-19 and their loved ones who are having to choose between their paycheck and their well-being. This situation hits me especially hard because Trikafta has recently given my life back. In fact, a life I never thought I'd have. But to be in the best of my health as an adult, yet having to be concerned about how my disability affects my employment isn't something I should have to be concerned with during a global pandemic. Thank you for hearing mine and other stories of how the most medically vulnerable are trying to navigate maintaining their employment and benefits during these unique circumstances.
Thank you so much to all our panelists. That was really insightful and helpful to hear the full range of perspectives on this challenging issue. And now we're going to start some questions and answers. I will encourage those of you participating online, joining us, to please submit your questions in through the Q&A section of the website. We look forward to hearing them. So let me get it started. I'd like to start with the clinicians on the phone, Dr. Brawley and Dr. Ellen. Let me say, we all know there's a lot of uncertainty here, and we're hearing that we may be dealing with ongoing waves of the coronavirus in the coming months until there's a vaccine. And here we are asking the federal government to provide paid leave for anyone who's at high risk of complications, including everyone with serious chronic illness. Dr. Brawley, the CDC just released some guidelines this week encouraging both individuals who are vulnerable to continue to shelter in place and encouraging employers to strongly consider special accommodations for personnel who are members of a vulnerable population. Can you help us build out this definition of who is high risk, who is this vulnerable population a bit more? Can you help us define this a bit more specifically?
Yes, thank you. Clearly, vulnerable people are people who have lung diseases, be it COPD or cystic fibrosis or other types of lung disease, to include lung cancer. Clearly, in my own world as a medical oncologist, the vulnerable are people who have active treatment for cancer. And I mention that because many of our patients who are being treated for lung cancer or not lung cancer, but for breast cancer, colon cancer, are very frequently folks who go to work. They get treated every 3 weeks, but they go to work in normal times. There are a number of different illnesses, and how we define vulnerable, by the way, is we have data to show that they have either an increased risk beyond the general population of contracting the coronavirus, or once contracting the coronavirus, they have an increased risk of a bad outcome.
And Dr. Ellen, I'd love to hear your thoughts on that same question.
Well, I think he answered it very well. We have looked at two different questions, and I think he separated it into those who are likely to become infected. And I think what we know are people who are clustering in different places are more likely, nursing homes, for example, are more likely to suffer consequences if someone comes in who's infected. But the real issue, without being cold-hearted about it, is preventing deaths and overwhelming the health system at the same time. And populations, the elderly, because of just just age itself and the accumulation of chronic disease, as well as people born with congenital problems that manifest, particularly in the case of cystic fibrosis, as lung severities, that we really need to be cautious about protecting them. And we know this is a highly contagious disease. We know that household contacts of people, and people working in closed spaces like an office, like a workplace, are highly vulnerable to getting infected. And what we hope as we go forward, and you talked about the mini outbreaks that are going to happen, is that they are going to happen in our workplaces. We know that's going to happen. Nobody is suggesting that with a downturn in cases and deaths that we're going to experience fewer, we're not going to experience any new cases. Well, of course, we're going to consider to have new cases, but they're going to be able to be contained. The problem is even if it's a small outbreak, if it hits a vulnerable population, the likelihood that they will get severely ill and die is much, much greater than for the general population. And that's where both the loss of life for those individuals, which is horrible and tragic, but also the policy implications of that are dramatic in that, and I don't want to be a fearmonger, but how when people experience, and we start hearing about deaths out there, people are going to start reacting to that in a good way and in a bad way. And so there is really the end game here is to prevent people who are vulnerable from being exposed to the virus itself. And it's inevitable that many workplaces will have moments of exposure. It's just that those folks will be able to weather that and will be able to contain it before it spreads too widely. But if it hits the workplace of someone who's either a caretaker for COVID and they get infected and then expose someone with a chronic disease, or you hit somebody who actually has a chronic disease like cystic fibrosis, there will be significant consequences.
Thank you both. That's very helpful and disturbing. Let me stick with the two of you for just a second more and ask you both to look into your crystal ball, which we know is next to impossible, but talking about timeline and how we should measure when the risk is lessened enough for workers to return. Is it widespread testing? Is it a vaccine? And how do we think differently about that question when it comes to a vulnerable population? So let me keep with you, Dr. Ellis, and flip the order.
Jeff, it quickly he already came up, but you want to go first? All right, I'll go. I think picking up on a point that I made previously, the issue of returning to work in normal capacity is something that I'm not sure that we're really ready for and will be ready for a while. I do think the idea that, my personal perspective is getting people back to work is essential for both their own benefit and the benefit of the economy, which is then benefits us all. And we are never going to have perfect conditions for restarting and reopening the economy and reopening businesses. We are going to have to take action to make sure we mitigate the risk of or contain the risk of outbreaks in office settings, for example, and in workplace settings and in restaurant settings. And so that will involve trying to change the density so that social distancing can occur in those spaces. And that has to happen now. That strategy works well. It's going to have, like I said, it's going to have outbreaks. We're going to have people get sick who have no chronic illness, and some of those people are going to die. But what we can do proactively is make sure that in those settings where we're taking all the precautions, bringing people back to work, which we have to do, and at the same time making sure we don't backslide on deaths and hospitalizations. We need to limit the exposure of people who would be most vulnerable if they got infected to having severe consequences. And that's where this discussion sort of takes place. So if you ask me in a crystal ball, there will be two factors. One will become people's, desire to say, look, I'd rather work and not stagger my work hours, be in the office all the time, or they're not given a choice because they're essential workers and they have no other pre-existing condition that would keep them from there, and that may push things along in one direction. The other may be, in other workplaces which are more cautious, will be till there's more immunity. And those are the two, I think, factors. But that does not, in both of those cases, there will be, events that occur, and the key is to keep people who are vulnerable away from those events.
And I would agree. I would agree with what's just been said. What's likely to happen with this disease over the next year to 2 years is we're going to have outbreaks. And I wouldn't think of it as one big tidal wave where we flatten the curve. I would think of it as a number of waves that are going to need to be flattened. And there are going to be outbreaks of the disease in various areas around the country. And the best way to combat these outbreaks is the way that it's been combated in several other countries. One of the reasons why we have more than a quarter, nearly a third of all the all the COVID deaths in the world in this country right now, whereas countries like Korea, which is about a fifth our size, have only 300 deaths. We have over 90,000. Is because of they implemented very good public health practices, and we need to implement those same types of very good public health practices. This involves identifying people who have the disease through testing, questioning, and other things, quarantining people who've been exposed, isolating people who actually have the disease. Good contact tracing is going to be really, really important in the future, as well as, I would say, quarantining or isolating people who are at high risk for having a very bad outcome from getting the disease. Now, we're going to have to practice some form of social distancing, some form of decreasing the density of the population until we either have herd immunity or a vaccine. I am hopeful we're going to have a vaccine in the future, but from what I know in terms of the molecular biology, it is indeed possible we may not have a vaccine. I still hope that we will, and some of the things I've heard recently are incredibly promising that we will, but I'm not willing to bet my next paycheck that we're going to have a vaccine. If we do have a vaccine, I can promise you that that vaccine will not be 100% effective, number one. And number two, there will be elements of the population for whom that vaccine will not be appropriate, especially people who have certain immunosuppressive diseases. Once we have a candidate vaccine and understand a little bit more about it, we will actually know a little more about, one, who will benefit from that vaccine, how much they will benefit from that vaccine, and very importantly as well, who really ought not get that vaccine. And those individuals are going to have to rely upon social distancing and isolation in order to protect themselves from this virus.
Thank you so much. Katie, I'd love to turn it to you. Hearing that, how are you thinking about your own comfort level returning to work and what you need to be able to maintain your employment and still feel safe?
Yeah, I work in a school with 2,800 students, so I'm exposed to a lot of people every day. And so it doesn't make me feel comfortable about having to possibly return to work. And as well, my partner, he works, like I said, in a very client-facing environment, and he also meets with a lot of different people daily. And so having us being exposed to multiple people a day is definitely nerve-wracking.
Thanks. Monica, we just heard from our other three panelists about the clear need to be able to maintain social distancing, especially for our vulnerable population. Let's pivot over to a potential fix, right? The potential fix of an expanded paid leave. Can you speak about why it's so essential and probably quite helpful to employers for the federal government to take on this component and be able to help us open up more?
Ultimately, employers were as caught off guard as the rest of us with respect to this pandemic. So they haven't really had an opportunity to prepare for shouldering paying for paid leave in the way that employers in states that already have this existing protection have had that time. So in existing models, we see where employees have been contributing to that opportunity through payroll taxes. And that hasn't occurred yet, obviously due to the nature of this pandemic. So as the federal government has stepped in to provide some assistance and protection in other areas, this is certainly an opportunity for them to do so again, because as I've mentioned, really, we're talking about individuals who just need an opportunity to bridge a gap between now and when it is safe for them to return to work. This is not an open-ended situation where they are never going to return to work again. And so this is, in fact, time limited.
Can I stay with you, Monica, for a minute, and can you build on what you just said and what the provisions that were in the HEROES Act passed last week? How do those provisions really help expand what we're talking about here and facilitate this gap that you talked about?
So certainly, I think that the reasons for provided leave in the HEROES Act is incredibly important. As I've mentioned, existing reasons for leave don't include quarantining because of being at high risk and being of a vulnerable population. So that's incredibly important. I think an incredibly valuable fix that's currently included in the HEROES Act is the expanded definition of family. So as I mentioned, under what we have started calling in our world traditional FMLA, individuals are only allowed to take time off to act as a caregiver to a seriously ill child, parent, or spouse. I would argue that for most of America, that's a very limited definition of family. In the HEROES Act, it was expanded to include siblings and, I believe, grandparents and domestic partners. And that's something that we've actually heard from a large number of people over the last couple of months, where individuals who are in committed relationships with another individual but aren't legally married don't have access to basically any legal protection. So by expanding that to domestic partners, that is very, very, I think, valuable for the communities that we're talking about.
Great, thanks. Dr. Ellen, I'd like to sort of keep with this theme of the value to the economy and to our vulnerable populations. As I mentioned at the outset, we're hearing a lot in the news about the proposals to limit legal liability for businesses in this pandemic. How do you see, and you wrote some about this, expanding paid leave as a component of some way to protect businesses and employers?
Yeah, one of the questions that has come up is, the idea of forcing or employers forcing their employees who are at risk to come back to work. And there has been discussion, as everyone has heard, about you open yourself up as an employer to the possibility of litigation related to what people would argue, at least in a tort, is that you have exposed them unnecessarily to COVID. And one of the argument, and I think people have read it, and I think if you've heard people respond to that argument, one of the places is that while there probably is necessary to stop frivolous litigation, because in many of these cases, they probably would not stand up if the employer was taking healthy actions. But the concern is that there'll still be frivolous lawsuits. And to the degree that you can limit to the employer that risk, and that risk could be limited by the fact that the one group who probably could get more solid standing would be those who are vulnerable. And so the argument goes that if you can protect the employer or support the employer in protecting their vulnerable employees by not requiring that they come in through extended FMLA, that you then not only benefit the employee and whoever else they're taking care of, but the employer.
Thanks. And can you build on that specifically for employees who have been dubbed essential, and your thoughts on that?
Yeah, I still think you hit the same issue, which is, the number of working adults with chronic disease, particularly severe ones, as was mentioned, like cystic fibrosis, like someone who's actively being treated for cancer. Those populations, having them come in is putting them at double risk, because a lot of the essential employees are at risk for exposure. And if you put the vulnerable population into that mix, they're at risk for death. And so I think that this FMLA policy should apply to them as well.
Monica, do you want to add anything in your perspective from a legal standpoint on what Dr. Ellen just said?
Well, I am not a tort attorney. I will say that I think that the government has a vested interest in supporting employers in keeping employees employed for a lot of the reasons that I talked about towards the end of my presentation, in that by maintaining the employees' long-term employment, they're going to continue contributing to all of the government programs that we ask most of working Americans to contribute to, including Social Security and Medicare. And I think that it also us avoid so many individuals then being forced to rely on additional public assistance, where, again, they just need to be able to bridge that gap.
Thanks. Katie, let me turn back to you and ask, sort of, as you think about a normal time, pre-COVID, what does paid leave look like for you typically? You mentioned that you need it for hospital visits and when you're sick, and how would this expansion really help you?
Yeah, I've been really fortunate in many ways to have a great team at Johns Hopkins that I work with. And being a teacher, I, in my normal time, get these nice breaks called summer. And that's actually one of the reasons that I picked being a teacher, is so that I would have that 2 months in the summer for self-care. So my team and I have really been able to, over the years, take that time to do the things that another person might have to be out of work for an extended time. So I've been very fortunate to have not yet had to take family leave, but on the regular daily basis during the school year, I do use all of my leave up pretty much, going to appointments and those rare and, well, sometimes rare, more rare now with Trikafta, sick days that I actually do need to take. So this would be, now moving into the fall would be a great need for me to not have to expose myself at a job I love. I love teaching. I love working with students. That's where I want to be. But it is a hard decision to have to put that versus, living.
Yeah, I think that you reflect what we're hearing from so many in our community, and I'm sure that Monica and Dr. Brawley are hearing in the cancer community, that people want to work, but striking that balance of protecting your health so that you can continue to work is critical. I think this is going to be our last question as we're nearing the top of the hour, and want to be mindful that people may be jumping on another call at noon. Monica, let me turn this to you. I spoke at the top of the panel about the things that we're seeing about some states trying to disenroll people at high risk of COVID-19 and their loved ones from unemployment insurance if they continue to self-isolate due to fears of contracting COVID-19. What do you see the ramifications of these policy decisions are? Actually, I feel like this is, if we could do a rule for everyone, just a few seconds from each of our panelists, we'll make this our last question. So the ramifications of removing that safety net.
Ultimately, I think that the states are just kicking the can down the road. So by disenrolling them from unemployment, that only compounds the financial and economic hardship that these families are already facing, and they're going to be forced to rely on other safety nets that may or may not exist. And ultimately, we have to think of what we want our society to look like. That are we going to work to protect the most vulnerable populations among us? Or are we going to abandon them?
Thank you. Dr. Brawley, your thoughts?
Yeah, I spend a lot of time working on the question of how can we avoid people dying. In many respects, this is an easy one. We simply need to support those amongst us who are most vulnerable, those amongst us who are going to suffer the most if exposed to this. And I spend a lot of time trying to figure out, how we're going to develop the next drug and so forth. Quite honestly, these sorts of interventions have the potential of saving far, far more lives than any next breakthrough cancer drug. And it is a shame in cancer and cystic fibrosis and other diseases that we would actually lose people in what are really preventable deaths. And if you look at the cost of preventing these deaths, it's actually quite inexpensive. I'll stop at that point.
Thank you so much. Dr. Ellen?
Yeah, I think we're learning pretty clearly that the number of what I'll call sporadic deaths, general population, community spread of people who are getting infected and dying, probably represents a minority of the people who are actually becoming infected and dying. And as Dr. Crowley said, we are very concerned, Brawley, about preventing deaths in the end. And the vulnerable populations, like I said, the elderly, those with chronic disease, those with congenital diseases, are most at risk for dying and make up probably in the end the bulk of the deaths that we're seeing. And as a society, we need to prevent as many deaths as we can. That's our mandate. And the way, and I think it was said very nicely, the most cost-effective way to do that is to prevent those people who are most likely to die, prevent them from getting infected, and then obviously making sure from there they don't die. So I think that continuing to take very aggressive preventive steps with that population of people will bear great fruit.
Thank you. And Katie, we'll give you the last word.
Yeah, currently I don't really feel that the social safety net is supporting medically vulnerable people and their families. It's my partner and I, one of many factors of not getting married has actually been what happens when I do get sick and I need a lung transplant and have to stop working. I've had many friends who have been married and have had to get divorced so their family doesn't face financial ruin. Like that is the way out. So to prevent that, we haven't actually gotten married. So it would be really great if there was legislation that would protect us in our non-married status for Family Medical Leave Act, and it shouldn't penalize us to not be included because of decisions we've made for many factors.
Thank you all. This has been a wonderful panel, and each of you brought so much insight and expertise into this very complex discussion and challenge. I really want to thank you all, the panelists, and thank all of those of you who joined in with us today. We appreciate it, and I want to just point to the slide on the screen of the specifics asked to Congress to expand paid leave for our most vulnerable population to facilitate us getting back to work and the economy restarting while providing a backstop and a safety net for those who need it most. So thank you all again. We appreciate everybody's time.